ourselves ni kitu gani akiendi vizuri, so that at least once we go out there using all the machineries including GAO, we'll be able to achieve the objectives that we have. Daktari, mimi niko tayari, because at least we should go somewhere. I remember sometimes, I don't know whether it was in the 90s, when we joined service, there was a tape that came out, was talking about breaking the silence. I think it was somebody, Rafael Tujo or something like that. And people were not talking about it. But later they broke the silence. Lakini mambo imeendelea ikibadilika, sindio? So as we move on, can we...
From the satisfied urban drivers or taxi drivers to take you around Mombasa for your security. Have a good day and enjoy yourself in Pride in Paradise. Thank you.
It was very sad, honestly speaking, that once you are diagnosed, we used to take those patients to the corridor, outside the ward. And they used to say, take them to the beach. The beach was a corridor where you are completely forgotten because the health workers had no solution. There was no guidance. Health workers were equally traumatized like the patients. You can get, then when we went to Kenyatta, you can get an admission of 40, 50 people at night, and you lose 10, 15 of them that night. And 90% of those deaths were HIV/AIDS. We've come from that time to this time now, where as a country, we have really covered grounds, and we're looking at a future of complete elimination. So this conference is very critical for us in the sense that we want to make the policies starting from the bottom. That's why we have our counties or grassroots people or communities here. So that
there are villages that will be there within the program. We have talking walls. Those are talking walls. Somebody asked what are talking walls. Talking walls are walls that have some information. So not some, those posters are from counties and they've shared some of their innovations. When you find time, please pass by. There's networking. There's declaration on the last day, and there will be an award dinner that we will have. So in terms of just phrasing the way the week, the 4 days will be, today we'll have the speeches in the afternoon, but in the morning we are doing a program update where this program is. We recognize that not all of us understand where we are, and so we'll have that in this morning. Then in the afternoon, we'll have the official opening. Tomorrow and Wednesday, there are several themes around integration models, what people have done, and we'll be listening in to our colleagues, our partners, our counties, with panel discussions on, wow, how does this work? What can we do to be able to move forward? On the last day, on the second last day is when we've planned for the gala dinner, but the last day on Friday, we are expecting to be joined by the Parliamentary Health Committee, because that's when we'll be discussing sustainability and around financing and investments beyond the service delivery. So at that time, we'll have a plenary where we'll be discussing what does this mean in terms of sustainability and financing. So I welcome you to enjoy, have fun, but please network. I am here influenced by a lot of people seated behind here. This county directors reaching out, CASCOs and partners and CECs, and I'm hoping when you leave here, at least you choose one thing that you can go and implement to make a difference. Thank you.
Thank you very much. You know, when Rossi talks about networking, I threw my eyes around and people are busy on their gadgets. So don't think the person you're seated next to is your next network. That networking with someone else. Before the end of the session, please make sure you change that they're speaking to you. I was just telling my neighbor, you haven't spoken to me in the last 5 minutes. So thank you very much. As you can see, we have a loaded program, very exciting presentations that are going to come. And there are awards as well. So you could be awarded. So please stay tuned in, don't leave. So without much ado now, we would like to switch gears. I would like to invite my co-chair, Dr. Gordon, I am told that the bills for power have been paid and therefore power will stay. Gordon, please welcome. Thank you.
Yeah, thank you very much, Dr. Sirenko. I hope the power will not go off on me, but we keep our faith. So ladies and gentlemen, my name is Dr. Gordon Okomo, the County Director of Health, Homa Bay, and the Chair of Directors Caucus. So much has been said, and a lot has gone into the space of HIV. I think Dr. Bashir has given us a history which makes us reflect backwards where we've come from. And for that, we thank everyone. All of us are heroes and heroines. We've made it in this space to make sure that at least we've reached this point where HIV at some point was like declared a death sentence. But now you can see people live and now they're aging with the disease. Isn't that a milestone? So let's give a round of applause to our researchers, our partners, ourselves, because all of us, in one way or another, we've contributed. As I wait for Lily Nyaga to upload her presentation, I wish we have Kayamba Africa give us one song as Daktari uploads her presentation. Kayamba Africa. Thank you. So as they organize themselves, we'll have Lily Nyaga present to us the HIV program update. Where have we come from? Where are we? I know there are disparities in different counties. In as much as Ross has said, according to the UNAIDS target for 2030, we're at 98, 98, 94. I'm sure counties differ, especially in the last 95. I'm sure counties differ in the elimination agenda of HIV to children, that we have aggressive target for 2027. So Lily Nyaga, as you upload, and Kayamba Africa, as you come on board, let's wait and see. Thank you. Kayamba Africa. Is Dr. Yaro in the room? Yeah, so as we wait for Kayamba Africa, Dr. Yaro, come and give us a chorus. I can see you directly. These are one of the champions for HIV. I remember working with him during option B plus. A research and a pilot that has made us now have elimination of mother-to-child transmission. I remember that during time we used to have nevirapine and all that. And that has made us see children, a generation born free of HIV to HIV-positive mothers. So, karibu sana.
Say no to gender-based violence. Now sing all those three. Let's start. You got to say no, say no. Say no to gender-based violence. You got to say no, say no. Say no to gender-based violence. Let's go. You got to say no. you're going to clap for yourselves. I don't know if Kayamba is ready. Great. So gender-based violence, we have to fight it for us to defeat HIV. That's right? Okay, I'll remind you to sing it again later.
Thank you, Dr. Patrick Oyaro. This gentleman hall is ready when called upon. So, Kayamba African, please.
Thank you. Ladies and gentlemen, with all due respect, can we just be upstanding? Just we stretch a bit. Yeah, we just stretch a bit. Stretch a bit, stretch a bit, stretch a bit. Yeah, this is Mombasa. And this is how we are going to stretch all of us. 20 cards.
Right. Sure.
Tushangilie Kenya, taifa letu tukufu, Kenya tunayoipenda. Tushangilie Kenya, taifa letu tukufu, Kenya tunayoipenda. Kenya yetu tunayoipenda. Twajivunia sana tukijiita wa Kenya, nchi yenye baraka. Twajivunia sana tukijiita wa Kenya, nchi yenye baraka.
Able to retain these mothers through their services. Another programmatic update is about the transition to 3-test algorithm. Following the WHO guidance for countries, especially with very low prevalence, the Ministry of Health, through NASCOP, has embarked on a journey to transition to 3-test algorithm. We, of course, have gone through the different processes, adapting the algorithm as a country according to the WHO guidelines, and we are now in the process of training the healthcare workers. We've already trained all the master TOTs, and we are now training by county, and we are looking to actually starting to effect the 3-test algorithm, in the month of July. So now we'll switch gears and go to quarterly performance review, and I will take us through the prevention program, the PMTCT program, care and treatment, and then I will hand it over to my counterpart to also tell us about county-led monitoring. So we continue to prioritize HTS for case finding through either provider-initiated testing or client-initiated testing. We do have multiple strategies for testing, either in outpatient, inpatient, also index testing, and many other testing strategies like SNS and also self-testing. In the last quarter, so this quarterly performance review is for the quarter January to March of 2024. So in that quarter, a total of around 2 million tests were conducted, 25,000 of which were HIV positive, yielding a positivity of 1.2%. And we were able to link nearly all the clients that were identified as positive at 91%. Of course, I will be sharing with you how some linkage looked like across the different counties. So we do have counties that were able to link all their clients. For example, Mandera had linked all the clients that they identified, Lamu, Vihiga, Wajir. But we also do have counties that had poor linkage, up to around 78%. And we do know that linkage is important for us to be able to optimize the treatment outcomes for the clients that we identify. So I did indicate that the big gaps for diagnosis exist among pediatrics, AYPs, and men. So I will be showing you some of the strategies that we are putting in to really improve and optimize our diagnosis among this population that is lagging behind. So when you look at the pediatrics, these are children who are below 15 years, you take note that index testing, which is really testing contacts of a HIV positive person, and in the pediatric group, that person will be the mother. So you realize that children of mothers who are living with HIV were more likely to yield a positive compared to the provider-initiated testing strategies. We are working very closely with the different programs to really close the gap for identification among the children. You realize that only less than 50%, at 46%, children are diagnosed below 2 years. And it's our hope that we can be able to strengthen our diagnosis so that we are able to capture these children on time. When you look at testing among men, index testing, and this is really testing sexual partners, was yielding 10 times more than the provider-initiated testing. So we continue to support the strategies that are likely to identify these men so that we can be able to also really identify them on time and initiate them on treatment so that they can also catch up and enjoy a quality life. Among the AYP, I think the story remains the same. Index testing yielding 9 times more than the other strategies. And so you'll be hearing a lot about how we are going to support facilities to really scale up index testing to increase awareness for the different subpopulations that exist. Self-testing, you are aware that self-testing is a strategy for reaching AYPs and men and other subpopulations that are more difficult to reach. We distribute the self-test kits either through the pharmacies or also assisted within the health facilities. So when you look at the graph on the right, you note that there is a preference, if I may use that word, for unassisted self-testing. So walking into a chemist and procuring the self-test and then administering it yourself. We also do have majority of the people who are using the self-test kits being aged between 20 and 34 years. Leveraging technology, we as a program have really been embracing technology to support us to improve service delivery. We continue to prioritize technology from prevention all the way to treatment by increasing, one, the uptake of the EHTS app. So we do have an app that we use like an EMR where as we're administering the HIV testing, we are collecting key information that then helps us to really think about and derive insights around the risks for the clients that we are testing. We are now incorporating machine learning to be able to stratify risk for the different clients that we test. And one of the insights that we take from the clients that we have been able to test in the last quarter is that out of the 53,000 clients that we tested, we were able to stratify, and the highest risk client had 13 times more chance of testing positive compared to a person who was categorized as a low risk. So how are you utilizing this data? We are ensuring that for the high risk for HIV transmission or acquisition, we are able, that test negative, we are able to link them to biomedical prevention services, and also being able to support even the low risk in terms of providing behavioral interventions. Sexual and gender-based violence, we just came from singing a song, and we know that it's a risk for acquisition of HIV, but also it interferes with how well we retain our clients on treatment and also how well they adhere to their treatment. So looking at the slide, we're able to see that majority of our sexual and gender-based violence clients that are being reported are aged between 14 and 24 years. I think generally this slide shows us that uptake of the gender-based violence package is pretty low, with just very few, less than 30% of clients across the different subpopulations being able to complete their PEP that is issued to them after confirmation of gender-based violence. Further on is really being able to look at the cascade around emergency contraceptives, and similarly, these clients are not coming on time. They are expected to come on time within 72 hours, so that then the package that is given to them is able to yield positive outcomes, and we have much fewer seroconversion for the people who have gender-based violence. So let's look at voluntary male medical circumcision. VMMC has been shown to confer partial protection for acquisition of HIV among men who are circumcised. The VMMC program is in 12 out of the 47 counties, and this is because those are the counties that, generally most communities in this country are culturally circumcising, and we target the counties that are not culturally circumcising. So we are in these 12 counties. We do have, in terms of the numbers, we've been able to reach around 5,000. Let's move next, please. Yeah, you can see we've been able to reach around 5,000 clients in the last quarter, majority of whom are aged between 15 and 19 years. In terms of how the VMMC program is able to really reach its target, there is a seasonality that is usually around school holidays, and so you can actually see the periods. There are some periods where we're actually able to really get more VMMC clients than others. Pre-exposure prophylaxis, I think the infection. The AYPs, similarly, quite a number of eligible AYPs, around 43,000 in that we are able to pick the disease on time. Finally, I think doing justice, the last comes, what do you say? You save the best for last. So talking about NCD integration and just really looking at the data that we have to see how well we are doing in terms of ensuring that we are looking at our clients holistically. Out of the 1.17 million people who are currently on treatment, whose data we have at individual level, around 60% have been screened for BP in their last visit, and we had around 39,000 that had been suspected to have high blood pressure. Only 300 had been screened for diabetes in their last visit. And I will be explaining why this is important, because then even though the data is little, it's able to provide some insights that we are able to really use to make decisions around the program. When you look at women of reproductive age, 500,000 of women who are of reproductive age that are currently on treatment, and only 12% have been screened for cervical cancer within the stipulated time for screening. Let's look at management for HIV clients. And I really just want to focus first on the overall. So all these clients, out of the 798,000 clients, we do female clients. We do have 23,000 who are known to be hypertensive, and only 75% have a well-controlled blood pressure. And the same for men, 71% well-controlled. But when you look at the viral suppression, you see that both the females and the males are 97% of them are virally suppressed, meaning that we may be sitting in our clinics and doing our due diligence for the HIV program, but really missing out on what is likely to kill this client, the diabetes or the hypertension. So looking at it, I think, much more closely, deeper. Next. So this is a table that really just goes to show suppression rates, really comparing suppression rates and controlling diabetes and hypertension. And you can actually see across the different subpopulations, of course, we are able to see how well and who is affected by the different subpopulations. But you can actually see that viral load suppression across all the subcategories is well achieved for all the subpopulations. But when you look at control for hypertension, ranging between 68% and 79%. And when you look for at the control for diabetes, ranging as well between 69% and 75%. So that's really calling for us to be able to be more vigilant in terms of ensuring that these integrated services are also offered holistically. So as I close, I really just want to have a call to action, using data-driven approaches to be able to reach the unreached. We've been able to demonstrate that individual level data is able to give us finer insights as to where we are lagging behind. Differentiated service delivery, and also just being able to use client-centered approach in our service delivery to be able to ensure that we are meeting the different subpopulations at their needs. Optimizing screening, diagnosis, and management for AHD. I have already highlighted that around the CD4 testing. Of course, thinking beyond HIV for clients, for our HIV population, which is really the essence of this summit, to look at how to integrate our services and be able to provide a holistic care for all. So as I conclude, I really just want to share this saying that a single leaf working alone provides no shade. So there is a lot of collaborations and partnerships that will take us a longer way, and there is also unfinished business. This is work that has been done by a number of partners, most of who are in this room, and so I was presenting really on behalf of that team, and I thank you.
You'll agree with me, it was quite a mouthful, but I believe you've picked up something. Moving forward, we want to recognize the presence of Brian Reitman from PEPFAR Country Office. We'll now have a presentation from NEFAC, that is Nelson Otuoma and team. And colleagues, you heard Dr. Bashir talk about the history a bit, and at some point the disease was called a thinning disease, if you remember well. A disease where you come to the hospital, the doctors and the service providers could don as if they were going to the moon just to attend to a HIV client. Families, villages were swept. And one could think that maybe we shook a hand with the devil, or was it a failure to humanity, or was that the end of the world? We are very happy that the story went up to when it was declared a disaster in this country. And we're happy that now we can talk about epidemic control. We have the communities that are affected, and they're with us here to give and affirm that science can work out. Science works out. Let's give applause to all the scientists who are in this room. I saw Professor Nduati somewhere. We have our professors. An applause to the CASCOs who do this job day after day. An applause to the directors who are the technical advisors to the counties. An applause to the CECs who give us leadership to ensure that service delivery is articulated in the county. And what we're coming to see today is a sign of strong partnership. We've partnered with different people, PEPFAR, UNAIDS, WHO, the UN family. Let's give them a round of applause. It's always important to get a feedback from the person you serve. And we want to get feedback from the team led by Nelson Otuoma, how community-led monitoring has worked out. This helps us see how do we improve our services and how we also check ourselves if the services are being offered according to the way it's supposed to be. So we call upon Nelson Otuoma. Let us give him a round of applause as he comes. Someone who has also stood firm and has supported the HIV program. Karibu.
Thank you, Daktari. We were giving applauses. Applause to communities. And that is really important. If you are here up to Friday, you will know that everybody else can participate. Communities get involved. So we'll be defining the difference between participation and involvement. Anyway, our director, Dr. Bashir, and the Ministry of Health Leadership, County Leadership, partners of the Ministry of Health and Communities. Actually, the presentation will not come from me. There are two brief presentations. In the program, they were supposed to come later in the day, so it sounded like ambush, and two of my colleagues were wishing the power can get lost again, but looks like it is here. The fact that the Ministry of Health and partners are investing heavily, and there is predictable and sustainable supply of ARVs free of charge in all public facilities, it is because of stigma. So as you move in the journey of integration, the most important thing to know is that you work with the healthcare workers, providers of care, and you need to be sensitive to the recipients of care and their feelings, including internalized self-stigma. Sometimes people feel they are stigmatized, actually that stigma is in them. And we need to partner together and work together so that we work with our colleagues, newly diagnosed, AYP men, so that they also come up and take and utilize services that we are going to offer during this integration. With that, I want to invite Dorothy. In communities, we are used to a lot of encouragement. So until she comes, we can be clapping for her. After Dorothy, we will have Joyce. I think we have two from NEFAC, but let's start from the community-led monitoring. Thank you very much, and welcome.
Thank you very much, Nelson. It's good afternoon. Distinguished guests, ladies and gentlemen, all protocols observed, good afternoon. I'm a member of NEFAC, and I am glad to be here to present to you on CLM, and thank you very much, NASCO, for giving me this opportunity to present in this very important meeting. Daktari, I'm glad, I'm one of those who are taken to the beach, but I'm glad I'm standing here now. So thank you very much, the scientists, the doctors. I can see Dr. Nduati, we worked with her many, many years ago when there was no medication and we used to just take anything that comes because of desperation, but now we are here because of the scientists. So we are no longer taking our urine or soil or things like those. And I'm sure as we move on, it will be even better. So my work here today is to present to you the community-led monitoring, and which is CLM in short. And CLM is a technique initiated and implemented by community organizations. There was a call for the same, and the communities that are implementing did apply for the same, and therefore we have a few organizations that are implementing in the few counties. So what I'm going to present today is just the data that has been collected between January this year to March. And basically we had a questionnaire that was being administered with the recipients of care, and therefore the outcome actually relies very much on the questions that were shared with the various clients or recipients of care rather. So, as you can see from the, I think the other slide. The first one. Yeah. We had 28,371 feedback collected between January and March this year. And as I mentioned, this was done by peer monitors or data collectors within the various facilities. And the facilities that we carried out, the same was supported by, most facilities are supported by PEPFAR. And of course, the grant also came from PEPFAR, but currently is being supported by UNAIDS through the PEPFAR funding. At least 68% of feedback provided by beneficiaries identified as female interviewed by peer monitors. So we can see that there was a high number of female who gave feedback on the various services that they get at their facility. 166 PEPFAR-funded facilities, I've mentioned that, and they were in 5 counties. And then we had 78% of the facilities were owned by government. Apart from the PEPFAR-owned facilities, then we have the government, 9%, and private sector and FBOs we had. For that also help us to ensure that whatever comes out of the client is being implemented at various levels. Then also monitor the community by CLM stakeholders to improve the quality of services and improve patient outcomes. So basically, I think those are some of the activities that were carried out between the short period that we have. As communities, you know, our work is in the community, so our presentation might be short, but we do a lot of work in the community. So thank you very much all for listening to me, and we look forward to continue working with you. Santini. I think I will now invite Joyce Amondi to come and present on the stigma index.
Good afternoon, everyone. Wapi makofi yangu? Great, thank you very much. So, my name is Joyce Ouma. I am going to be presenting about the Stigma Index 2.0. I think Nelson spoke a little bit about this earlier. I promise I tried to cut down the slides. Ziko mingi, but si mingi sana. So just bear with me. But I'd like to take this opportunity first to talk a little bit about NEFAC. So NEFAC is a national network that unites people living with HIV and those that are affected by TB and AIDS through organizations. As you go through the day, you might hear people saying that they're from NEFAC, so it's important that you know who we are, and I'll also tell you in a bit why I'm starting my presentation by telling you about NEFAC. So with the mission to contribute to the quality, health, and well-being, we had 36 key informant interviews, and we also worked very closely with key populations, that is the MSMs, the gays, the lesbians, transgender groups, and people who use drugs. And our sampling was based on venue-based sampling, and we also did qualitative informants and participants using the FGDs and the key informant interviews. Next slide. In terms of the period for the data collection, data was collected between the period of December 2023 to February 2024. And I know a lot of you will be asking us why the short period. It's simply because that is how much our resources allowed. So we managed to conduct our feedback collection during these processes and during that period. And we electronically collected data using the Open Data Kit, that is the ODK, Kobo collection. And as I mentioned earlier, we did focus group discussions and we did qualitative analysis, and we also used a software called the QSR and Vivo version 14. Do not ask me about that one. You can ask me about everything else on that slide, but not that version 14. So the next slide. So we're about to get into a little bit of a somber mood because now we are going to be talking about the findings of the stigma index. Our stigma index, we managed to reach a population of 1,305 people living with HIV who participated in the stigma index 2.0. 780, which is more than 50%, were females, and 525 were males. And 26.6% of the respondents were also from the key populations. And of course, there is an age group that has been mentioned here a lot today, that is the adolescents and young people. They were also represented by 23.9% of the respondents, and yeah, many other populations above 25 hizo mnaweza soma. Next slide. Okay, so one of the things, one of the parameters that we were looking at when conducting the stigma index was the knowledge of HIV status. And of course, because we were working with, we were collecting feedback, we were collecting data from people who were already living with HIV, we noted that 49.2% of the participants have known their status for over 10 years. Nimeona wengine wanajiita elderly aging with HIV, so they could be the ones. And then an overall of 75.6% of respondents have been aware of their HIV status for more than 4 years, with women, as always, accounting for 78.7% and men for 68.4%. So some of the respondents also reported that their partners were HIV positive, and I think I also have to reiterate that when we were talking about, when we were conducting this study, we were very key on ethical engagement, so no one was coerced to respond to any of these questions, and most of this was disclosed because we were talking to them, people living with HIV to people living with HIV. So 56% of the respondents also stated that their spouses were aware of their HIV status, whereas only 29% reported that their children were aware of their HIV status. Again, that's a very sort of a glaring gap when it comes to HIV-related disclosure, what, when, why, and how. Next slide. In terms of testing and treatment, and I started this slide with a sort of like a disclaimer at the top, that this was largely dependent on the commodity availability and the set guidelines by the Ministry of Health. So out of our respondents, 63% of the respondents voluntarily chose to undergo HIV testing, while 10% were tested without their knowledge, and 3% were forced to take the HIV test without their consent. Now, as I said, we are about to get deeper into many human rights violations, but again, these are the findings of the study. 68% of the respondents hesitated to take a HIV test due to fears of negative reactions from people, including family members, friends, employers, or other community members. And that is how glaring the stigma circle is. It starts from inside with your family, it goes to the secondary, which is your friends, and then even at your workplace, it continues to affect the lives of the person living with HIV as a whole. And then 97% of the respondents have been or are currently on HIV treatment. I think that was already demonstrated this morning when we were talking about how we are doing when it comes to the 95-95 cascade. So at least we are doing well when it comes to the first 95, but then we also need to focus more on the indicators that are stigma related. Next slide. Just building deeper onto the experiences of stigma and discrimination, and if you go through our stigma index report, if you haven't gone through it, wait, I should have started by saying how many people have heard of the stigma index 2.0? Why is it that only hands in the front are going up? Backbenchers, how many of us have heard of stigma index 2.0? Oh yeah, the hands are getting, all right, okay. So please do make sure to get the report because all these findings that I'm rushing through are there. But among the top 3 forms of stigma and discrimination that were reported by the respondents in the last 12 months, number 1, discriminatory remarks from other people. There was discriminatory remarks from family members and friends, and then there was verbal harassment. That's the kind of, the most kind of pervasive stigma that people living with HIV have experienced. Cumulatively, more women have experienced verbal harassment and also physical harassment. And you may wonder why we also went further to gender disaggregate this kind of data. It just shows that in most instances, women, and I'm biased because I'm a woman, are experiencing harassment and human rights violation more than our male counterparts. So more women have been excluded from family activities and social gatherings. And you can imagine when we were conducting this study, you had to hear the instances, the examples, and the very painful stories that these women have had to live through. Next slide. Another easily overlooked aspect is the internalized stigma. So we also when conducting the study, we talked a little bit with the respondents about the stigma, and 73.6% of the participants admitted finding it difficult to disclose their HIV status to someone, while 71.3% acknowledged hiding their HIV status from others. Now, while this numbers is quite high, it also shows that this is how much we are still struggling with people coming to terms and accepting their HIV status, and in retrospect also how do they adhere to treatment and how do they achieve the highest attainable quality of health. 39.5% reported feeling guilty, worthless, and ashamed of being HIV positive. And this, as I said, this was a difficult study to conduct. So I'm not going to go through that bit, but please do get a hold of the report just to know how much and how deep internalized stigma has affected people living with HIV. Next slide. This one, I would like for us all to listen. This one is when it comes to healthcare access. Again, largely dependent on availability of commodities and set guidelines by the Ministry of Health. 75.2% of the respondents accessed healthcare in government or public clinics or facilities, while 14.9% accessed their treatment through private entities, that is the NGOs and private clinics and FBOs. 43% of respondents reported the existence of community-led clinics providing accessible HIV-related service. And like I said, it wasn't entirely bad news. In some instances, we were actually doing great, while 5.4% reported not having a viral load test in the last 12 months. And we all know why this is the case. And for those who do not know, currently we conduct viral load tests for folks who are above 24 and who are doing well on treatment about once in a year. Yeah, okay. And then 39% of respondents missed or decided to stop their HIV treatment due to fear of someone learning their HIV status. And this was cited due to the lack of confidentiality at the facilities. Again, sexual reproductive health and rights issues. 12.6% of the respondents were pressured to take HIV tests during pregnancy, keyword being pressured. 6.7% were pressured to use a specific type of contraceptive. 3.2% were advised to terminate a pregnancy because of their HIV status, and 4% were advised not to father or mother a child because of their HIV status. 10% indicated that they underwent sterilization without their consent, and 14% of the participants stated that they were denied access to contraception or family planning resources. That's how deep stigma is. This slide lists a whole lot more of other data that talks about the rights and the abuses of key populations who are experiencing more than just one form of stigma. And I will not go deeper into the numbers, but we have different subpopulations within the key population that each time they attempt to seek health services, they fail because of the stigma at the health facility. Imagine being a person living with HIV, belonging to the KP community, and still facing some of these many issues that are listed on this slide. Next. So in terms of actions taken, you'd envision that this slide would be as long as the slide with the issues, right? But that's not the case. We only have very few actions that were taken. Only 3% of the abused participants took any action in the last 12 months. 35.9% of those who did not take any action attributed it to lack of knowledge, and because they did not know about the structures, they did not know about the tribunal and stuff, and 13.9% feared involuntary disclosure of their status, while 71% were aware of the existing laws and others did not know. I'm almost finalizing. I know I'm standing between you and lunch. So in terms of our conclusion, HIV-related stigma is still a major challenge for people living with HIV in all diversity and needs to be tackled with urgency. We've made progress in terms of treatment, we've made progress in terms of the HIV prevention and HIV treatment guideline and cascade, but stigma still remains a big issue as we are dealing with attitudes, perception, and people's knowledge base. And HIV stigma still takes many forms, and different subpopulations experience stigma differently. On to my last slide, which talks about the recommendations, and I would like for all of us to listen on this one, as this is the recommendation from people living with HIV to all of us in this room, because I believe this is a multi-stakeholder convening. So governments and partners should invest in community leadership to tackle community issues. This is just the tip of the iceberg. There's so many issues that communities are encountering. NASCOP, NSDCC, and people living with HIV networks should work hand in hand to ensure proper integration of services and awareness creation on the existing policies and laws to protect people living with HIV. This also communicates my expectations for this summit, because we are talking about integration programming, because communities have come together and used our life and lived experiences as evidence for programming. And now, because SHIF is the new kid on the block, the Social Health Insurance Fund, there's need to ensure that we are not leaving communities behind when we are talking about these issues, and ensure that HIV and us as people living with HIV are included in these discussions. I will not leave this stage until you clap for me. So thank you, and you can clap. Thank you.
Thank you very much, Team NEFAC. Nothing for us. Nothing for us. For sure, nothing for us without us. That's the power of the community. I know it's lunchtime. We all have something that looks close to what I'm holding here. A ticket. All right. So before we break for lunch, I would like to call my co-chair to make an announcement. Karibu. I hope the power is not going to.
Okay, for us to avoid a blackout, he will stand here with me. Thank you very much. I would like us to clap for ourselves up to this point. Can we clap for the community for the scientific presentations? Asante sana. Now over to the announcement. Please keep your questions. I know you have many up to this point. We are supposed to have a plenary discussion at this point. Unfortunately, we will push it ahead. We are going to take a lunch break, and when we come back in the next 45 minutes, we are going to have a special opening session. Our cabinet secretary has confirmed that she may join us virtually to open this session, and therefore that's why we are taking this break now. I do not think we are together. I hear mamas. Whether it is in agreement or not. So this is how we're going to do it. I would like to request the guests seated on row 1. Please, you will leave the room first, followed by row 2, then the rest of us.